In this last section, we're going to talk about restrictive lung disorders as opposed to obstructive lung disorders and respiratory distress. So restrictive lung disorders, it's a group of disorders with impaired lung expansion and reduced total lung capacity. So with the obstructive disorders, there was something that was obstructing the lung or reducing the amount of gas exchange. With this one, it's impaired lung expansion. So in the first group of restrictive lung disorders, they're caused by an abnormality of the chest wall that impairs or limits lung expansion, like kyphosis or scoliosis, poliomyelitis, amyotrophic lateral sclerosis, which is Lou Gehrig's disease, ALS, botulism, or muscular dystrophy. So there's some other disease that's causing, that's limiting or impairing lung expansion. So with polio, with kyphosis or scoliosis, it's structural. With polio, it's a microorganism causing it, and people during the acute stage often have to be on a ventilator. Of course, with polio vaccines, it's very uncommon anymore for anybody to get polio. With ALS, a lot of times it's in the later stages of the disease, and people again have to be on a ventilator. Some people choose not to be. Botulism, it's caused by a bacterial toxin, and muscular dystrophy, it's caused by a genetic disease. So there are a lot of things that could cause that abnormality, and so depending on what it is, it's going to change how you treat it, except that a lot of them end up having to be on a ventilator. That's often the treatment. The second group of restrictive lung disorders are diseases that affect the supporting framework of the lungs. So idiopathic pulmonary fibrosis and what they call occupational diseases like asbestosis. So we'll talk about some of those. So pneumoconioses, it's chronic restrictive diseases resulting from long-term exposure to irritating particles. So the inflammation as a result of those irritating particles getting inhaled into the lungs causes gradual destruction of connective tissue, and you lose functional areas of the lung. The onset is insidious over years, and usually dyspnea is the first symptom. The treatment is stopping your exposure to whatever's irritating your lungs and treatment of any infection that results from it. So these are the occupational ones that we're talking about. So coal workers inhaling coal dust, people around stone cutting or sandblasting inhaling silica, people in insulation or shipbuilding inhaling asbestos, or farmer's lung where you're inhaling fungal spores from hay. So pulmonary edema is fluid that collects in the alveoli and interstitial area. There's that one picture from the book that I think we looked at on one of the slides that had the alveolus full of fluid, basically. So it can result from a lot of different primary conditions. But the upshot is it reduces the amount of oxygen diffusing into the blood and interferes with lung expansion. So if you have inflammation of lung in the lungs, if you have inflammation in the lungs, it increases the permeability of capillaries, right? And the plasma protein levels are low, so it decreases the osmotic pressure of the plasma, and you get fluid in the lungs, and you can develop pulmonary hypertension. So cough, orthopnea, which is difficulty breathing when you lie down flat, rales in mild cases, hemoptysis, coughing up blood, and frothy blood-tinged sputum. The treatment is to treat the causative factor and supportive care, and possibly positive pressure mechanical ventilation. So a lot of times if you're seeing people in the hospital with pulmonary edema, they are on serious oxygen. You are not taking them out of the room or doing any exercise or anything without their oxygen on there. So a pulmonary embolus, it's a blood clot or a mass that obstructs pulmonary artery or any of its branches. The effect of the embolus depends on the material, size, and location. So you can have small pulmonary emboli, and they may be silent, like they say, because they're only involving a small area of the lung. But a large embolus can cause sudden death. It can completely block off your breathing. 90% of pulmonary emboli originate from deep vein thromboses in the legs, and they are preventable. So, I have a couple of pulmonary embolus stories, I guess. One of my friends who's a marathon runner, so obviously very fit, she lives in Michigan, so she cross-country skis in the winter and does a lot of her running training indoors on the treadmill. In the summer, of course, she runs outside. She works at home and on the computer most of the time. And she was feeling sort of one day, and her husband was getting ready to leave for work, and he looked at her and said, "Are you okay?" And she goes, Yeah, I'm fine. I'm just a little tired. And he says, "Okay." So she's working at home. He went off to work, and he came home at lunch because he just didn't feel right about the way she looked. And he said, "I think we ought to go into the doctor." She said, "Okay." So she ended up going in. They sent her to the emergency room. They admitted her to the hospital. She was in there for a week. She had pulmonary emboli. And so she didn't have any major symptoms, except she just didn't feel good. So malaise, I guess you would call it. And her husband noticed something different about her. So for the year after she got out of the hospital, she had to be on heparin. She had to inject it every day to avoid further clots, and took her a while to get back to her marathon training. But a similar thing happened to a patient that I was treating after a total knee replacement. He was doing fine. He was a relatively young, fairly fit guy. He was doing good with his range of motion and good exercises, and he just wasn't feeling on top of his game, but he just had knee surgery, so he just kind of chalked it up to that. And his wife said, "I don't like the look of you," and took him in, and he had pulmonary embolisms. So I guess the moral of the story on this whole thing is trust your spouse. If they don't like the way you're looking, listen to them. So sometimes the signs and symptoms can be transient chest pain, cough or dyspnea when you have small emboli. Larger emboli can cause increased chest pain with coughing or deep breathing. Tachypnea or dyspnea that develops suddenly, and later on hemoptysis and fever. Hypoxia causes anxiety, restlessness, and pallor, and tachycardia. So sometimes that feeling of anxiety or restlessness is caused by hypoxia. So if you're not feeling right and your spouse looks at you and says, "Gosh, you're pale," go into the doctor. A massive emboli can cause severe crushing chest pain, low blood pressure, rapid weak pulse, and loss of consciousness. So the difference between a really small one versus a massive one, it's a huge difference, but any of them can kill you. So the prevention is before you have surgery. So clearly the man who just had the total knee replacement had a complication from surgery. So before surgery, a lot of times the doctor or surgical staff will teach you about what you need to do. They'll teach you about doing ankle pumps, moving, using anti-embolic stockings, using exercises to prevent thrombosis, and use of anticoagulant drugs. So part of what we can do in physical therapy is to reinforce those. You got to wear your compression socks. You have to do your exercises. You have to take your drugs as prescribed. The diagnosis is usually done by radiography, lung scans for pulmonary, MRIs, and pulmonary angiography. So they definitely look at your risk factors, like just having had surgery, that's a risk factor. Prolonged bed rest and compression stockings. Sometimes they put a filter into your vena cava where it filters out those clots. Sometimes the heparin or streptokinase, which are blood thinners. Sometimes they have to put you on a ventilator. Sometimes they have to do surgery to get the embolus out if it's a really big one. So lung expansion disorders are the other type of restrictive disorder. So atelectasis is the non-aeration or collapse of the lung or part of the lung. It leads to decreased gas exchange and apoxia. So basically the alveoli become airless, they get sucked shut and they collapse, and inflammation or atrophy of the alveoli occur. The process interferes with blood flow through the lung, obviously, because the pulmonary capillaries are where the blood flow happens. So both ventilation and perfusion are altered. It affects oxygen diffusion. So lots of different things can result in atelectasis. An obstructed airway, basically, because the alveoli are no longer inflated and they collapse. If there's a tumor or something exerting pressure on part of the lung, that can cause them to collapse. Increased surface tension in the alveoli can prevent expansion of the lung. It's like that surfactant doesn't work, there's surface tension and they hold together. So with asthma, when they do the positive pressure breathing, that is to prevent atelectasis. Fibrotic tissue in the lungs or pleura can restrict expansion and lead to collapse of the alveoli, and it can happen after surgery. It can be a complication of surgery. If you're getting the idea that surgery is dangerous, you're right, it is. So here are just some of the different things that can cause atelectasis. So if there's a small area of atelectasis, it can be asymptomatic. You're just not getting as much surface area as you would have, but it's just a small area. Large areas can cause dyspnea, difficulty breathing, increased heat and respiratory rates, and chest pain. So pleural effusion is where there's the presence of excess fluid in the pleural cavity. It causes increased pressure in the pleural cavity and separation of the pleural membranes. Remember, those pleural membranes kind of suck together, and that's part of your lung recoil. So you could have effusions due to exudate as a response to inflammation. You can have watery effusions, they call it a hydrothorax, that results in increased hydrostatic pressure or decreased osmotic pressure in the blood vessels. So that fluid balance that we talked about last quarter is really important on the function of your lungs. Fluid gets in the wrong places, it can screw up your life. The signs and symptoms of pleural effusion are dyspnea, cyclic chest pain, so it hurts when you try to breathe out, and then, on the cycle. Increased respiratory and heart rates. Treatment usually involves removing the underlying cause and to treat for respiratory impairment. So a lot of times they will analyze the fluid to see if it's an infection or what's causing it. Sometimes they'll do chest drainage or thoracentesis, where they drain part of the lung to remove the fluid and relieve the pressure. So a pneumothorax, as opposed to pleural effusion, is air in the pleural cavity. So pleural effusion is fluid in the pleural cavity. Pneumothorax is air in the pleural cavity. A closed pneumothorax, the air enters the pleural cavity from internal airways. There's no opening in the chest wall. You can have a spontaneous pneumothorax, which is a tear on the surface of the lung, and it fills up the pleural space. The air does. A secondary pneumothorax is usually associated with some kind of respiratory disease, some other respiratory disease. It could be like the rupture of the blebs from emphysema on the lung surface, or erosion by a tumor. So these are different types of pneumothorax. The closed is where it's the source of air is internal. The open is there's a puncture wound through the chest. So the treatment and the signs and effects are different, and the treatment is different. All of these are serious, obviously, because you can't expand the lungs. They're restricted. So an open pneumothorax is where atmospheric air enters the pleural cavity through an opening in the chest wall. Sometimes they'll call it a sucking chest wound because it's sucking air in through an opening in the chest wall. A tension pneumothorax is considered the most serious form. It's the result of an opening through the chest wall and the parietal pleura, and there's a tear in the lung and the visceral pleura. So there's a tear all the way through. Air entry into the pleural enters into the pleural cavity as you breathe in, but the hole closes on expiration. So you can see how the air gets trapped and leads to increased pleural pressure, and it can lead to atelectasis, causing the alveoli to collapse. That's why it's considered the most serious. So flail chest results from a fracture of the ribs, which allow the ribs to move independently during respiration. So during inspiration, the broken section moves inward rather than outward, because normally it's that bucket handle. The inspiration, the ribs go out, but the broken part goes in, gets sucked in rather than going out. The inward movement of the ribs prevents expansion of the affected lung. A large flail section can compress adjacent lung tissue and push air out of that section up into the bronchus. So the stale air from the damaged lung can cross into the other lung with newly inspired air. So a lot of times open sucking chest wounds and flail chest, they happen from traumatic agencies. So you're in a car accident, you're in a ski accident, you're in a motorcycle accident. That's when this kind of stuff happens, a gunshot wound. So these are 911 situations. During expiration, the flail section is pushed outward because you have that increased intrathoracic pressure. And if you have a large flail section, it alters the airflow because normal airflow, the lungs go out and up for inhalation and down and in for exhalation. If part of it isn't cooperating, you get altered airflow. And the air from the unaffected lung can move across into the affected lung. So you have limited expansion and you can get hypoxia. So here's the little graphic from the book with the flail chest injury. The ribs are loose and it's affecting airflow basically. So adult respiratory distress syndrome, also known as ARDS, results from an injury to the alveolar wall and the capillary membrane and causes the release of chemical mediators, increasing the permeability of capillary membrane, so it's an inflammatory process. Increased fluid and protein in the interstitial space, damage to the surfactant producing cells, so that could cause atelectasis, diffuse necrosis and fibrosis if the patient survives. There are tons of predisposing conditions. It's often associated with multiple organ failure or organ dysfunction. So when somebody gets to this stage, they are likely not going to survive. Dyspnea, restlessness, rapid shallow respiration, increased heart rate, combination of respiratory and metabolic acidosis. The treatment is to treat the underlying cause and supportive respiratory therapy. So one of the best parts about working in physical therapy in the acute care setting is that there are respiratory therapists there. They do wonders with someone who can't breathe. So if you ever get a chance to work with a respiratory therapist, they are wonderful people to have around. So this is the graphic from the book on adult respiratory distress syndrome. We are frequently not seeing these people in PT because they're not suitable for PT, but it's good to know what goes on with them. With acute respiratory failure, it can result from acute or chronic disorders. So people with emphysema or a combination of chronic and acute disorders, acute respiratory disorders like pneumonia, neuromuscular diseases like ALS, they can be masked or altered by the primary problem. So someone has emphysema and they suddenly have more trouble breathing. It can be masked by the fact that they always have trouble breathing. So in order to treat acute respiratory failure, the primary problem has to be resolved and supportive treatment to maintain respiratory function. So a lot of times this person's on a ventilator with acute respiratory failure. So as PTAs, we might be seeing this person, they might be in ICU on the ventilator, and we're doing passive range of motion with them just to maintain their joint health. We're doing positioning with them while they're on the respirator.